Yeah, that's what I was more worried.
So one of our graduating residents, Dr. Pillay, is going to talk about the fluid administration in pediatrics, an overview of some key issues that we all need to be aware of when we're taking care of children in terms of fluid requirements and how to determine.
All right. Good morning. So I'm gonna talk about fluid administration in pediatrics. I'm mostly going to kind of try and talk about, kind of give a brief overview of the history, fluid administration in pediatrics, and then kind of go into what's being done now. I have nothing to disclose. So objectives this morning is understand the history of the use of maintenance water and electrolyte therapy, and discuss new recommendations for maintenance fluid therapy, specifically isotonic versus hypotonic fluid administration. So before we get into that, I think it's important to kind of go over some of the basics. Total body water is a percentage of body weight that varies with age. It's kind of shown in the figure here. So the fetus has high total body water, which decreases to approximately 75% of birth weight for a term infant, or 75% of birth weight, and for a term infant, decreases to 60% of body weight during the first year of life. Fat has a lower water content, therefore by the end of puberty, females' total body water decreases to approximately 50%, while males stays at approximately 60%. Overweight children, many of which we have in our clinic, also tend to have a decreased total body water. So, talking about fluid compartments, total body water is divided into two main compartments, your intracellular fluid and extracellular fluid. So the ECF is larger in the fetus and newborn, but during the first year of life, the ECF and ICF approach adult values. The ECF is about 20% of total body weight, while the ICF is 30 to 40% of body weight. Your ECF is further divided into plasma water and an interstitial fluid. Plasma water makes up about 5% of your body weight, and blood volume makes up approximately 8%. And that's with a hematocrit of approximately 40. The volume of plasma, water, and interstitial fluid can be altered in pathologic conditions, including dehydration. So there's a delicate balance or a delicate equilibrium between intravascular fluid and interstitial fluid. The balance between hydrostatic and oncotic forces helps to regulate the intravascular volume, which is critical for tissue perfusion. So loss of fluid from the intravascular space may compromise intravascular volume, placing the child at risk for inadequate blood flow to vital organs. This is just a graphic representation of kind of your cations and anions in plasma and intracellular fluid. Let's pay particular attention to the plasma because we'll kind of go over that in a little bit. All right, the concept of osmolality. So ICF and intracellular fluid and extracellular fluid are in osmotic equilibrium because the cell membrane is permeable to water. So if the osmolality in one compartment changes, then water movement leads to equalization of osmolality. Plasma osmolality is normally 285 to 295 milliosmoles per kg. So osmolality is tightly regulated and maintained at that level. Water intake and excretion maintains normal plasma osmolality, and osmoreceptors in the hypothalamus sense plasma osmolality. So elevations in osmolality lead to secretion of ADH to increase the reabsorption of water in the renal medulla, and then when volume depletion is present, both the thirst center in the hypothalamus and an increase in ADH secretion occurs. Plasma tonicity. So, plasma tonicity, also called effective plasma osmolality, is the parameter sensed by osmoreceptors and determines the transcellular distribution of water. So water can freely cross almost all cell membranes and moves from an area of lower tonicity or higher water content to an area of higher tonicity or lower water content. So the main difference between plasma tonicity and plasma osmolality is that plasma tonicity reflects the concentration of solutes that do not easily cross cell membranes, so mostly sodium and sodium salts. And therefore, it affects the distribution of water between cells and the extracellular fluid. So I'm going to switch gears and talk a little bit about the history of intracellular fluids or of fluid use in pediatrics. So discussions about body fluids really began in the 1800s with descriptions of what they call an internal milieu or like an internal environment. Physiologists then began to conduct a more complete picture of human body's fluid compartments. Between 1920s and 1930s, a physician named Gamble, while studying the influence of fasting to treat seizures, was able to describe the renal response of extracellular fluid depletion. This led to the concept of extracellular fluid, and shortly after, he and his colleagues were able to describe extracellular fluid and the complex interaction between plasma and the interstitium. Now, in the early 1930s, physiologists were describing the use of salt and sodium bicarb infusions to treat cholera patients, and there are also publications describing continuous IV drips to treat dehydration. And then between the 1930s and the 1940s is when a lot of the kind of mainstay of where we are today came from. So there was like significant contributions by physicians named Darrow, Pratt, Butler, and Wallace. So Darrow and Pratt introduced the concept of deficient therapy, maintenance therapy, and the importance of potassium deficiency and dehydration. Butler and all used body surface area to determine water needs. And Wallace and all used a series of formulas to determine water needs based on age and calories. So what does all that mean? From all that information, two physicians named Holliday and Seeger published this article back in 1957 in the Journal of Pediatrics. What they did is they devised a scheme to permit an estimate of total energy expenditure, or expenditure of energy from weight alone, using a relationship between weight and expenditure of energy. So instead of relying on kind of new information or doing research, Holliday and Seeger used the compilation of information that was already proposed by their colleagues to develop a formula to define maintenance needs for water and parental fluid therapy. This is a little excerpt from the article. So Holliday and Seeger compared 4 distinct systems of measuring water needs. The first system was the need for water estimated to be 100 ml per 100 kcal. 2, the need for water to be 1,500 ml per meter squared in a day. The need for water estimated to be about 120 ml per 100 kcal dependent on basal activity and calories. And the need for water estimated by age and calories. So these 4 systems is kind of what was proposed by their colleagues before Holliday and Seeger. And from this, they devised a simple method of defining maintenance water needs. This is kind of a busy slide, so I'll just kind of summarize it. And I actually had to kind of read it a couple times to kind of understand it, so I'll do my best to simplify it for you. So the method involves a simple-to-use formula that relates the average calorie expenditure of a child of a given weight in kilos. So the infant up to 10 kilos in weight expends about 100 kcal of energy, kcal per kg. The child from 10 to 20 kilos expends 1,000 kcals plus 50 kcals per kg. And in the child weighing more than 20 kilos, the expenditure is about 1,500 kcals plus 20 kcal per kg. What does that remind you of? The 150-20 rule. And so that's where they devised this rule. They also stated that the allowance of about 50 ml per kg in a 24-hour period will replace insensible losses, and about 66.7 ml per kg in a 24-hour period will replace urinary losses, so that a total of about 110 to 100 ml per 100 kcal expended every 24-hour meets appropriate water maintenance needs. So this is the Holliday-Seeger method, kind of what I just described. So that's the 150-20 rule. This is the 4-to-1 rule, what we kind of use way more in pediatrics. So the 150-20 rule is calculates your maintenance fluids in a 24-hour period. Your 4-to-1 rule bases it on a 24-hour period. So just reading it in a child less than 10 kilos, 4 ml per kg per hour. A child weighing 11 to 20 kilos, it's 40 plus 2 ml per kg for each kg between 11 and 20. And then anything over 20, it's 60 plus 1 ml per kg per hour for each kg over 20. The way I kind of think about it in my head that makes sense is 40 ml for the first hour for the first 10 kgs. And then for the next 10 kgs, it's 20 ml per hour and 1 ml per hour for every kg after that. That's what kind of works for me when I'm calculating maintenance fluids. So a couple points that are important to note. Body weights greater than 65 kilos. In body weights greater than 65 kilos, water increments do not show the same incremental increase as with lower weights. So therefore, total maintenance water needs are generally capped at 2.4 liters daily. It's also important to know that calculations based on weight overestimate the water needs of overweight children. So in some overweight kids, it is better to base calculations on lean body weight, which you can estimate by using the 50th percentile of body weight for the child's height. Okay, so that little snippet about the history of where intravenous fluids come from. So what about today? So today the goal of fluid therapy is to preserve the normal volume and electrolyte composition of body fluids. So maintenance therapy replaces ongoing daily losses of water and electrolytes occurring via physiologic processes, so in urine, sweat, breathing, and in stool. Healthy children can tolerate significant variations in intake because of the many homeostatic mechanisms that can adjust absorption and excretion of water and electrolytes. So although urinary losses are approximately 60% of the total, the normal kidney has the ability to markedly modify water losses. So maintenance water is supposed to be designed to provide enough water so that your kidney does not have to significantly dilute or concentrate your urine. So if you have someone on maintenance fluids and they're peeing a whole bunch of clear liquid, you probably have them on too much maintenance fluids, or you can stop the maintenance fluids. It also provides a margin of safety so that normal homeostatic mechanisms can adjust urinary water losses to prevent overhydration and dehydration. So also remember that the calculated water and electrolyte needs that form the basis of maintenance therapy are not absolute requirements. So they're instead meant to provide guidelines for a starting point to estimate intravenous therapy. So these guidelines assume that there are no disease process present that would require an adjustment in either the rate or electrolyte composition of fluids. What are some conditions? Congestive heart failure, nephrotic syndrome, liver diseases, and neonates as well. Neonates have kind of a unique physiology, and that's their physiology is outside this scope of this discussion. Okay, what does Nelson say? So Nelson says children do not need to be started on intravenous fluids simply because their intake is being monitored in a hospital, and they are not taking maintenance fluids orally, unless there is a pathologic process present that necessitates high fluid intake. So us as clinicians, we need to recognize when it is necessary to begin maintenance fluids. So Nelson also says a normal teenager who is given nothing by mouth because overnight for a morning procedure does not need to have maintenance fluids, because a healthy adolescent can easily tolerate 12 to 18 hours without any oral intake. In contrast, a 6-month-old who's NPO for surgery the next morning needs to be receiving intravenous fluids within 8 hours of the last feed, because infants dehydrate more quickly than older patients. So, maintenance fluids are composed of water, glucose, sodium, potassium, patients lose water and sodium and potassium in their urine and stool, and water is also lost from your skin and lungs, kind of what I mentioned. So maintenance fluids replaces these losses, thereby avoiding development of dehydration and deficiency of sodium and potassium. The glucose provides approximately 20% of normal caloric needs of the patient and prevents the development of starvation ketoacidosis and diminishes protein degradation that would occur if the patient receives no calories. Excuse me. Glucose also provides osmoles to the fluid, which avoids the possibility of hemolysis if hypotonics are administered. So prototypical maintenance fluid therapy does not provide electrolytes such as calcium, phosphorus, magnesium, and bicarbonate. But we can always have those added to fluids if your patient needs it. So this chart is a comparison of some different isotonic fluids, and it compares it to kind of your electrolytes in plasma. So you can see sodium chloride with glucose, Plasma-lyte, lactated ringers. So of these isotonic solutions, Plasma-lyte and lactated ringers are most physiologic to plasma. It doesn't show hypotonic fluids, but hypotonic fluids are pretty easy to figure out. Your half normal saline is going to be just 77 millimoles of sodium, 77 of chloride, and your quarter normal is going to be 34 of sodium, 34 of chloride. So the question is, why do we use half normal and quarter normal saline? Well, one of the reasons is Nelson says the usual maintenance fluid therapy for children are half normal saline and normal saline. So it has to be right? But where did this recommendation come from? Holliday and Seeger had another contribution. It wasn't just water requirements. They recommended us to use half normal saline or quarter normal salines as maintenance. And the premise behind choosing those fluids, or hypotonic fluid, was due to being able to kind of meet a child's daily sodium and potassium requirements. So hypotonic fluid would essentially meet expected daily sodium requirements. And although they gave those recommendations, this is a little snippet from the actual article. It says, with respect to maintenance needs for electrolytes, less precise data are available, and figures considerably in excess of the minimum requirements are readily handled. So this fact is apparent in comparing the electrolyte intake of infants receiving human milk and cow's milk. So what do? They looked at the composition of human milk and cow's milk. They also looked at some work done by Darrow before them. And they came up with a recommendation somewhere in between human milk and cow's milk. And it's important to recognize that it's the recommendation, so sodium 3 milliequivalents per 100 calories per day, or 100 ml of fluid per day, and not per kilo. And again, that's a little snippet from it. It is also apparent that these values fall between the intakes of provided by human milk and cow's milk, and should therefore be acceptable as maintenance needs for electrolytes. So what's the problem? This has been done for 50 years. What's the problem with hypotonic and isotonic fluids now? So in 2003, this paper was published in the Journal of Pediatrics. It reported, it's kind of like a retrospective study. It looked at case reports not a retrospective study, sorry. It was a literature review that found to be more than 50 reported cases of some kind of neurologic morbidity or mortality, including 26 patient deaths, and in the past 10 years in hospitalized children who were receiving hypotonic fluids. And they kind of attributed these deaths to hospital-acquired hyponatremia. So half of those cases were in the post-op setting in previously helpful children who underwent minor surgery. So the conclusion of this article was kind of isotonic maintenance fluids should be used to prevent the development of hyponatremia. That was in 2003, and since then there's been quite a few other studies, case reports that have come out. What's the theory behind the ADH or the hyponatremia caused by isotonic fluids? So most of the literature that I looked at states that hospitalized children are at risk for what we call non-osmotic ADH secretion. So osmotic ADH secretion obviously is in response to changes in your osmolality. Non-osmotic means that it's independent of osmolality. So increases in non-osmotic ADH secretion leads to impaired free water secretion. That coupled with hypotonic fluid administration leads to hyponatremia. There are numerous conditions that are associated with non-osmotic ADH secretion, and this is kind of an overview of that. In a lot of the research, the main ones were CNS infection, pulmonary disease, and medications. But it also mentioned things like pain, vomiting, all can cause non-osmotic ADH secretion. So let's talk a little bit about hypotonic versus isotonic fluids. In 2013, this article was published in Pediatrics online. So this article was a meta-analysis. It searched PubMed, Embase, Cochrane Library, and clinicaltrials.gov for randomized control trials up to April 2013 on the safety of isotonic versus hypotonic IV maintenance fluids in hospitalized children. They looked at relative risk, weighted mean differences, and used 95% confidence intervals. Their 95% confidence intervals were calculated and based on the effects of plasma sodium. So the risk of developing hyponatremia, which was determined to be a sodium level, or plasma sodium level less than 136, severe hyponatremia, which was a plasma sodium level less than 130, and hypernatremia, which was a plasma sodium level greater than 145, was evaluated. So what did they find? They looked at several studies that had a pretty rigorous inclusion and exclusion criteria. In the end, they used 10 randomized control studies and reviewed about 855 subjects. The analysis showed that hypotonic fluids significantly increased the risk of hyponatremia with a relative risk of 2.24, 95% confidence interval, and a p-value of 0.0001. They did note that one study was excluded from the analysis because it defined hyponatremia as plasma sodium less than 130, and when it was included, the results were similar. What about severe hyponatremia? Kind of found the same thing. So in regard to severe hyponatremia, pooled analysis showed that hypotonic IV maintenance fluids also significantly increase the risk of severe hyponatremia with a relative risk of 5.29, 95% confidence interval, and a p-value of 0.003. This study found that there were no significant difference between the two interventions in the risk of hypernatremia. So the systematic review and meta-analysis confirmed the early findings that hypotonic maintenance fluids was a risk factor for hospital-acquired hyponatremia in pediatric patients. So hospitalized children often have more than one stimuli for excess ADH secretion, and this is thought to contribute to impaired ability to excrete free water. So hypotonic fluids with more free water than isotonic fluids are more likely to cause a positive balance of free water in pediatric patients, and thus the development of hyponatremia was contributed to the impaired ability to excrete free water when hypotonic fluids were administered. So that was in 2013. So since then, there have been several other meta-analysis of randomized controlled studies. They differ by either the study selection that they did, the statistical method, the inclusion or exclusion criteria, or their study characteristics. This study here, published in 2015 in the Journal of Pediatric Emergency Care, reviewed databases from PubMed, Embase, and Embase from January 1980 to about May 2013. They used 8 randomized control trials totaling 752 patients, and results showed a significant lower risk of hyponatremia with isotonic solution and isotonic intravenous maintenance fluid did not increase the possibility of hyponatremia. This study was done also in 2015. I'm sorry, this one was in 2013. This one was in 2015. It was published in the Journal of Pediatrics. It searched Medline, the Cochrane Central Registry, Cumulative Index for Nursing and Allied Health Literature, and Pediatric Academic Societies from 1946 to 2013. 10 studies totaling 752 patients were included in this meta-analysis and concluded that hospitalized children in ICUs and post-operative settings, in hospitalized children in ICUs and post-operative setting, the administration of hypotonic maintenance fluids increased the risk of hyponatremia when compared to isotonic fluids. This study also concluded that for patients on the general wards, there wasn't sufficient data based on the studies that were reviewed to make a conclusion, and individual risk factors need to be assessed. This study, published in 2014 in the Cochrane Library, searched the Cochrane Registry of control trials, Medline, Embase, ISA, Web of Science, and clinical trial registries up to June 2013. Meta-analysis included 10 studies and 1,106 patients, and found that when isotonic fluids were used, sodium levels in the body was less likely to be low. The results for serious adverse events with isotonic or hypotonic fluids were uncertain. And finally, this study, published in 2015 in the Journal of Pediatric Nephrology, included 11 randomized controlled trials totaling 1,095 patients, concluded that current evidence does not support the standard practice of prescribing hypotonic saline solution as maintenance intravenous therapy to hospitalized children. They also concluded that although there was no single intravenous fluid composition ideal for all children, an isotonic saline solution does appear to be safer choice when maintenance fluid therapy is used in the general pediatric population. So I know that I mentioned earlier that there's a study that came out that showed all this morbidity and mortality, deaths and neurologic problems with hypotonic fluids. These meta-analyses didn't actually show a whole lot of adverse events. So they showed hyponatremia that was less likely to be caused with isotonic fluids, but in these 4 meta-analyses, there were, 1 death and 1 seizure believed to be due to encephalopathy. But the authors noted that that could have been due to an improperly administered fluid, so either giving fluids for too long or in an inappropriate rate. So I'm going to talk a little bit about isotonic versus hypotonic fluids, but before I do, isotonic fluids versus hypotonic fluids and dehydration, before I do, I just wanted to mention a couple of things that are not really what I intended to speak about in this discussion, but I came across in my literature review. There are guidelines to help you in the management of gastroenteritis and dehydration in pediatric patients. So these guidelines were published by several different professional societies, American Academy of Pediatrics in 1996, CDC in 2003, Canadian Pediatric Society in 2006 and in 2011, the WHO in 2004, and the European Society for Pediatrics in 2014. So all of the guidelines agreed that oral replacement therapy is recommended for children with mild to moderate dehydration, and IV fluid administration should only be used for severe dehydration. So the guidelines state that patients with mild to moderate dehydration should receive 50 to 100 ml per kg of oral rehydration solution over 2 to 4 hours to correct the deficit of ongoing losses from vomiting or diarrhea. Oral rehydration solution should be administered in 5 ml amounts via syringe or teaspoons, and should be administered every 1 to 2 minutes. So despite these recommendations, in some of the literature that I read, it's not really, oral rehydration is very underused in the US. So that's all I really want to say about that. I encourage you to kind of read up on that on yourself, because it's not just guidelines about oral rehydration, it's guidelines about the use of antiemetics, refeeding, and there's some really good guidelines in there that I think is important for us as pediatricians to know. So back to isotonic versus hypotonic fluids. So in dehydration, IV administration of fluids in treating dehydration should only be done in severe cases, such as those with shock, altered mental status, or paralytic ileus, or with failure of alternative rehydration techniques used for mild to moderate dehydration. Problem with that is I don't know if you could admit a patient for failed oral rehydration therapy to put them in hospital to give them oral rehydration therapy. That might be part of the problem why it's underused in the US. So isotonic fluids is recommended to restore circulatory volume, excuse me, because hypertonic or hypotonic solutions may lead to cerebral edema and alter electrolyte composition. And so that's when you want to restore circulatory volume. So this study, published in the Journal of Pediatric Nephrology in 2010, looked at the incidence of hyponatremia in children with gastroenteritis treated with hypotonic fluids. The authors reviewed medical records of 531 otherwise healthy children with gastroenteritis who were admitted for IV fluids. The mean age was about 3.3 years, plus or minus 3 years. Excuse me. The authors retrospectively collected data on 124 of those patients who received 2 serum electrolytes on admissions and 4 to 24 hours later. The remaining children did not have sufficient laboratory values, and so they are excluded. All patients were treated with IV hypotonic saline as maintenance or maintenance therapy plus deficit. They noted that 100 patients receiving isotonic boluses for volume resuscitation all had a decrease in serum sodium by about 1.7 milliequivalents. So the results showed from this study that of the 97 who were isonatremic on admission, 18 developed hyponatremia following fluid therapy. 19 were mildly hyponatremic on admission, and interestingly enough, of those 19 that came in hyponatremic after treatment with hypotonic saline, 73% became isonatremic. The authors attributed this to a probable correction in dehydration after either prolonged IV fluid therapy and cessation of ADH secretion, secretion of water, and correction of hyponatremia. So these authors in this study concluded that prolonged hypotonic fluid use in gastroenteritis has the potential to cause hyponatremia, but they also say that a controlled prospective randomized study is needed. So several other studies found similar findings in ICU and post-op patients that were cited in this article. However, the authors in this article were kind of quick to point out that these studies, there are some problems with these studies, like they did not report the incidence of acquired hyponatremia, or they reported patients not on a recommended, or they reported that patients were not on a recommended maintenance rate or had prolonged fluid therapy. There have been some arguments against the use of isotonic maintenance fluid. This was by Holliday in 2005. It was in a letter to the editor. He stated that rapid and generous expansion of the extracellular fluid suppresses ADH secretion. And once it has been expanded, hypotonic fluids can safely be used as maintenance. He proposed the key to preventing hyponatremia when using hypotonic fluids is to suppress ADH secretion before undertaking maintenance therapy. Aaron Friedman also argued against the use of isotonic fluids, stating that extracellular fluid, kind of the same thing, extracellular fluid contraction needs to be corrected prior to the use of hypotonic fluids. But Friedman also proposed that more research needs to be conducted. So kind of that's what the literature is out there in regards to using hypotonic versus isotonic fluids. And that chart that I showed you earlier about normal saline, comparing normal saline to Plasma-lyte to lactated ringers, I kind of want to talk about the difference between Plasma-lyte and normal saline, because that has been, I'm sure everyone has heard of, been a topic in our hospital and in other institutions and in our ICU. So the most commonly used isotonic fluid is normal saline. However, there is emerging evidence for balanced solutions to avoid hyperchloremia. There are no longer randomized control, there aren't any randomized control trials comparing normal saline with any of the balanced solutions like normal salt or lactated ringers in either adults or children. And most of this growing literature is coming from animal models. There was one randomized controls trial that I found in 2016 that compared normal saline to Plasma-lyte in pediatric gastroenteritis. They measured plasma bicarbonate and used a dehydration score, but the study had to be stopped early due to slow enrollment. I did find this article. It's a clinical review. Came out in 2016 in the World Journal of Critical Care Medicine. It's a review of Plasma-lyte. It's a review of Plasma-lyte and isotonic fluids. It states that buffered intravenous crystalloid solution with the physiochemical composition that closely resembles human plasma, and there's emerging data to support the use of improving physiochemical outcomes. However, at this point, more randomized control study trials are needed to measure clinical outcomes, such as morbidity and mortality. So there seems to be evidence and a shift away from normal saline to Plasma-lyte, but right now there's not a whole lot of randomized control studies regarding morbidity and mortality to back those statements up completely. But a lot of institutions, including this one, already started to make the switch to a more balanced isotonic fluid. Okay, so the conclusion here is there's overwhelming evidence to support the use of isotonic fluids for maintenance over hypotonic fluids in pediatric patients with no underlying disease process that would require an adjustment in either the volume or the electrolyte composition of maintenance fluids. I think one of the key concepts, or what we need to think about, is we need to think about IV fluids as a medication and not just water in a bag. If we start treating IV fluids as a prescription and as medication, I think we'll better be able to think about whether or not our children need IV fluids. And when some of the articles and the Nelson's kind of all recommended that in children, if we do place them on IV fluids, we need to monitor things. So it's not like, here, put them on IV fluids and then they're eating and drinking, so let's cut it in half, or they're eating and drinking more, let's stop IV fluids. So what we really need to be doing is monitoring weights daily. We need to be monitoring urine output. and electrolytes to identify overhydration, underhydration, hyponatremia, and other electrolyte derangements. So part of my research, I found a couple things. So there's these nice guidelines published for use in England. It gives protocols for intravenous fluid therapy, and it's actually fantastic. And there's another one that I found that I'll show you in a little bit. So, and this is used all over, it should be used all over England. So it kind of gives you an overview of everything to do with fluid. So your assessment and your monitoring. So use body weight to calculate IV fluid. You may use body surface area to calculate body or fluid needs. It gives you recommendations in term neonates, and it gives you things that we should be following to assess for assessment. Gives you a table regarding clinical features of dehydration and hypovolemic shock. It gives you recommendations on fluid resuscitation. Gives you recommendations on routine maintenance. And it even gives you recommendations for term neonates, because like I said, neonates kind of don't follow the same guidelines as everyone else. Let's see. Gives you recommendations on replacement and redistribution, managing hyponatremia that develops during IV fluid, managing hyponatremia that develops during IV fluid, how to monitor for symptoms of hypo or hyponatremia, and then training and education. So it gives algorithms too. So this will probably be a little easier to follow, but algorithms regarding assessment and monitoring, regarding fluid resuscitation, regarding routine maintenance. So really, this guideline really is looking at fluids as a prescription, a medication, not just IV fluids or fluids and electrolytes in a bag. Again, replacement and redistribution. And then there's also this guideline that I found. This is at the University of Toronto, Sick Kids in Canada. They really do treat it as a prescription. So IV fluid maintenance in children, assessment and prescribing recommendations. So it was, this is the second version. It was approved in 2016. The next revision date will be in 2019. Gives a little algorithm here. So to determine indication for IV fluid. So are we doing maintenance, bolus therapy to replace abnormal losses, like from GI tract? This says complete assessment. So they recommend order lab tests prior to giving fluid administration, because if you don't know what your sodium and potassium are, how do you know where you're going to order? Ongoing assessments for all patients receiving maintenance fluids, and then some recommendations about determining fluid selection and prescription. So it also gives some guidelines, so definitions of acute hyponatremia, clinical practice recommendations, indications for prescribing IV fluids in pediatric patients, general principles, assessment and prescription of IV fluid therapy. So I wanted to point this out. Randomized control trials suggest that compared with hypotonic saline, the use of isotonic saline for maintenance IV fluid requirements is less likely to result in hyponatremia and does not increase the risk of developing hypernatremia. D5, quarter normal saline, D5W, and D510 all contain substantial amounts of electrolyte-free water and must not be used as maintenance IV therapy. So at sick kids, quarter normal or 1/3 normal, I don't even see that, you can't even get in the hospital. And you can only use those fluids in ICUs, CCUs, NICUs, and if you do need to use it, you need to consult a nephrology service. And in some of the literature that I read too, and I think it mentions that in Nelson's, that quarter normal saline is no longer recommended as a maintenance fluid. This even gives you guidelines on what you should do with fluid therapy depending on what your sodium requirements are. So those are a couple practice guidelines that I thought were interesting. You can take a look at those. I'd be happy to send the links to Jessica, and she can email them out and you can find them. The only thing is, I found this a few weeks ago, and when I try to find it again, it says the webpage is not available, so I don't know if you can only access it here. I couldn't access it from home. Okay. Questions?
That was a really nice elucidated all of the principles that are really important for IV fluid therapy in children. And I think the second conclusion, probably the most important, which is that you need to really pay close attention, monitor weight, follow the patient carefully. Because when you give IV fluids, you can get into a lot of trouble if you're not following the details. So I think that's been a very important presentation. So, and then I always knew that the principle always was that if the kidneys were working, they were your best friends for IV fluid to correct any issues, but you can't always rely on the kidneys because sometimes it gets fooled with inappropriate ADH secretion and so on. So I think it's really important that you follow these principles carefully. Questions?
One reminder is to always think about where other sources of sodium in hospitalized kids. So a lot of antibiotics or sodium salts,
Right.
and you can end up with some electrolyte issues just because of what you're also giving the kid the size of fluids.
Right, and another thing that I didn't mention too is it's very common when you put someone on maintenance fluids, you might have started them on, 2 antibiotics, and so some of those antibiotics come in a 50 milliliter bag of fluid, and if you're getting that 4 times a day, that's adding to your fluid, your total body water. And I know in an ICU setting, you look at all those things when you're calculating fluids, not so much on the general floor. So keep that in mind when you order fluids as well.
So, great review of all the literature, and so obviously the next questions are, do you feel that there is overwhelming evidence out there to change our practices here in this hospital? And if so, what practices are we going to change?
So I think there are. Definitely moving from hypotonic fluids to isotonic fluids. I know there's a big push to move from normal saline to Plasma-lyte. Based on the literature that's out there, I mean, it makes sense physiologically. Plasma-lyte closely resembles your plasma. So it makes sense, but just there's not enough literature out there that looks at morbidity and mortality that says, hey, Plasma-lyte is safe to use over normal saline. I think normal saline has been used for a number of years, but I definitely think that we need to start getting away from using hypotonic salines. And I think we need to do a better job of monitoring our kids in hospital who are on fluids. So we frequently put kids on fluids, and then, like I said, oh, they're eating great. Okay, or they're starting to eat okay, so let's cut the fluids in half. Oh, they're eating fine now. Let's cut the fluids entirely. But that's not really a great mechanism. In the literature that I read, I haven't read anything where that was okay to determine if whether or not fluids need to be increased or decreased. So I think we need to do a better job of monitoring. All right, if I'm going to do IV fluids, I need to get a weight every day. I need to monitor their intake and their output. Stuff like that to see if, okay, have we corrected the fluid volume? Can we stop IV fluids? And treating fluids like a prescription, I think, will kind of help us get there.
What is our current practice for routine maintenance fluids?
Typically, routine maintenance fluids in the babies, what we've done traditionally is D5 quarter. It really should have 20 of K in it if you're looking at sodium and potassium requirements. And so in the babies, it should be D5 quarter with 20 of K. As the kids get a little bit older, we typically move to D5 half. Again, it should have 20 of K in it, and we always forget to order that. And then, you know, just watching the kids, if they're third spacing a lot, then we'll usually move up to the normal saline. But it sounds like we shouldn't be doing any of the hypotonic fluids anymore. I mean, so did you find enough evidence in the literature to completely move away from that, and we should be doing D5 Normasol in these kids?
So
like in everybody?
In
or? Normal,
healthy kids. So you have to look like, why is the child being admitted to the hospital? What are their, what's the sodium level pre-hospital admission before you even administer fluids? And all of that should help you determine what fluid we put them on. But our practice here has kind of been, like you said, younger children, quarter normal, they get older, half normal, and we're not thinking about anything beyond that. So in that regard, yeah, I think we can change our practice guidelines to not getting rid of, but finding a better solution than half normal or quarter normal fluid.
And I'll tell you, at the children's hospitals where I was at before I came here, nobody used quarter or half normal. This was the first place I came to that actually still used that. So that's why it was really surprising to me, because everywhere else, every other children's hospital the two others that I was at in Texas were all using Plasma-lyte or Normasol as their fluids for every age group. They weren't using half or quarter at all.
And that's just for regular maintenance, like your respiratory kid that needs a little bit of extra volume, but they can't eat.
Yes, they did not have quarter or half at all. They all used the Plasma-lyte. I mean, that was in San Antonio, that was in Fort Worth. I know people at Dallas, they were that way too, so.
Texas Tech also, yeah.
So
St. Louis,
Colorado. St.
Louis
Louis too, Colorado.
Colorado are only by nephrology prescription.
Yep.
Overall, they can use half maintenance on the floor. Yes, they do half with 20 of K. That's what they use sometimes. Or most of the time, it's Plasma-lyte also.
And another thing to keep in mind too is that the holiday serum method is just a guideline. So if you feel like your patient is a little dry, you calculate maintenance fluids, but you don't think your patient needs all that fluid, you don't need to give exactly what is calculated, or you don't need to give anything at all. So these are just guidelines that are proposed. We need to assess. First thing you need to ask is, does my patient need to be on IV fluids? If it's no, then don't start IV fluids. I think that's.
And like you said, if they're getting antibiotics and they're getting a
Right.
large volume through the antibiotics, then we may not.
Right.
And I know typically most of the antibiotics default to D5 as what they're mixed in.
D5 normal saline, yeah.
No. When
Oh, just
pharmacy,
D5.
when pharmacy mixes the antibiotics, most of them are mixed in D5 because the majority of our meds are compatible with D5. That's the default. So when you have a diabetic that comes in, or one of our CF patients that are very sensitive to all this dextrose in their IV fluids, you have to call pharmacy and specifically request them to mix it in normal saline. You can do that, but everything defaults to D5 in this hospital. So you have to be aware of that. So our kids are getting a lot of free waters to begin with in all of their IV administration. And you're right. You look at that in the NI. You even count flushes in the NI. On the floor, we forget about it, and we shouldn't. Because they're getting a lot of extra fluids, and a lot of it is free water fluids from the D5 and their antibiotics and their other meds.
Right.
One of the things I think we also need to do, we'll need a lot of nursing education, because for me, when I was a resident, when I tried to give little babies Normasol, I got a lot of pushback, like, no, we just do quarter for the babies. So, and you know, especially when it's at night, it gets overwhelming. You don't want to be going back and forth. So if we're going to change the practice, then we need to educate the nurses. I'm really glad you did this topic, Vic, because it's really important, and we just downplay it most times. And I agree with you that we should look at IV fluids as IV antibiotics. So we need to do a better job in our outpatient and emergency room setting when we have kids coming in with decreased bio intake. we need to really spend time to reassure the parents that it's okay for you to give your child some Pedialyte, even if it's 5 cc's every couple of minutes. They don't need to come in for IV fluids, because look at all the things we're gonna have to do. We need to monitor the weights, the urine output. Like, you know, I mean, if this child is really making tears and is having, and just refusing to drink some popsicle, we just need to spend that extra time. And if they're reliable, we know that they come for their appointment, they have good transportation, they can get to the hospital. It's okay to discharge them and just have, you know, close follow-up. You can bring them back the next day to reassess rather than just bring them in. If you feel they are not reliable, then, you know, you have to document that clearly, that stage, you know, I don't really think it's an admission, but for social concerns, you know, parents are not reliable, they cannot do this. That case will put the patient in the hospital for this, and we need to be doing everything that you talked about, monitoring the urine output, the weights, and all that. And I think it would probably decrease the number of children that we're just bringing into the hospital and just giving IV fluids.
And the recommendation, and for your board exam too, is you always go oral hydration therapy first.
Yes.
And from what I read, and what I said earlier is what they recommend is you orally replace deficits over 2 to 4 hours by giving 5 ml by teaspoon or syringe every couple of minutes. So you need a reliable parent to do that. So if someone comes into the ED, studies have actually shown that when you do oral replacement therapy in the ED, it actually takes less staff, nursing staff, hospital staff to treat. Your ED readmissions are lower because you're allowing the parent to rehydrate their child. So they're like, I can sit at home and do this. I don't need to be in the ED. So it's actually better. But again, like I said, to have someone sit in the ED for 4 hours and you spoon feed them, or parents spoon feeding them small amounts is not cost effective. And then if that doesn't work, are you going to admit a child for oral hydration therapy? I don't know if someone can talk to billing and find out, like, hey, because that's what the standard of care, that's what the recommendation is, oral hydration therapy for mild to moderate dehydration. Is that something that's billable if we admit for after you fail? I mean, those are questions that we need to figure out. But I mean, you need a lot of positive things for that to happen.
I think if we do decide to move towards hypotonic fluids, like some sort of nursing training, because even if you order daily weights, for instance, you have to ask them to do the weight. They get frustrated. In ISO, strict ISO, I know we had some renal kids with Dr. Baliga. It's really hard to just get these basic things that we should have to monitor properly.
I think this grand round versus our current practices makes it very clear that we need to review this and update our standard protocol for maintenance therapy. So we'll do that.
I think these are basically just guidelines that need to be followed on normal kids, but each kid needs to be individualized. And if you have a kid with DI who comes with a serum sodium of 150, you can't be giving normal saline.
Right.
I mean, I had a kid that was transferred at Children's in New Orleans with a serum sodium of almost 200 and renal shutdown. He was dialyzed, but the kid did not survive because he was almost brain dead.
Yeah,
That's the word of caution.
Right.
and I think understanding the reason that the patient is in the hospital, and understanding whether there are underlying conditions that modify the normal approach is really important. But I do think that
So if you have a kid that comes in with dehydration and normal saline is the practice, if you find that the serum sodium is starting to go up, then obviously you are doing something wrong.
Right. And that's part of why we need to monitor electrolytes. So we need to, if you're admitting someone for dehydration and you're putting them on IV therapy, we need to be getting a sodium level before IV fluid therapy, and then recommendations that are at least 4 to 24 hours after administration of IV fluids, because you need to know what the sodium is doing.
So
I
in,
think this is, I'm sorry.
sorry. So in summary, we should not be prescribing IV fluids just for convenience to the patient or to the caregivers.
Because they're in the hospital.
And actually, there are nice models in other countries, particularly developing countries, that they have oral rehydration clinics for kids with gastroenteritis. Would check in the morning, they would be assessed, and then they would be prescribed oral rehydration solutions. And again, there is a protocol to that. After some point, you start to alternate that with water, but there are techniques to that. You teach the parents, you spend some time and just tell them you have to give 1 spoon at a time and wait a minute, and then very slowly. So it takes patience, it takes time, but it works. So I think we should be also concentrating efforts on that. Also, sometimes our diabetic patients, just for ketones, they don't necessarily need IV fluids, and sometimes you would hear me saying, let's calculate the daily fluid requirement, divide it into hours, and then let's ask them to drink that much water per hour for a few hours, and let's see what happens. So in general, every patient is unique, and we have to tailor these treatments to our patients, but just as an algorithm, starting from the simplest to the most complex is.
And I do want to say that in some of that literature about gastroenteritis, it said that a truly, because I know you have that problem when a kid comes in and like, he doesn't want to eat or anything, you give him a bottle, he doesn't want to eat it. Kids that are truly dehydrated are thirsty, and so they will drink. So kids that are, mildly dehydrated or just a little dehydrated and are refusing the bottle, those aren't the kids that need IV therapy. Those are kids that need small amounts of fluids given to them every couple of minutes to rehydrate them. Because, like I said, dehydrated kids are thirsty and they will drink fluids.
Okay, well, in the interest of time, we need to close this discussion, but I think that the board multidisciplinary committee is going to be looking at standardizing our approach to maintenance fluids. So, thank you very much, Vic.
Thank you.